All right. Well, thank you so much for that introduction, Dr. Welton. Um, as you said, I'm in dermatology, we do concern ourselves with disorders of the skin, hair, mucous membranes, but most importantly for today, the nails. So today will be a talk about simple, humble onychomycosis with a spotlight on systemic antifungal therapy. I don't have any disclosures, and I will be discussing off-label usage of medications. So with that, what are my objectives today? I first want to give a bird's eye view of onychomycosis. What is it? Who gets it? What patients can reasonably expect from treatment, depending on these things. I want to hopefully convince you guys to clip the nail, curette the nail, whatever it takes to confirm your diagnosis before initiating systemic therapy to help exclude, alternative diagnoses, which are in the differential. And finally, I want to give a little help to terbinafine, which I feel like it's a bad rap sometimes. I want to help demystify, destigmatize it, and kind of better contextualize what its side effect profile and hepatic risk is, and also give a bird's eye view of other present and future alternative options. So with that, um, onychomycosis, it's the most common nail disease by far. It constitutes a plurality, if not an outright majority of the nail pathology that I see day to day in clinic. Our highest powered studies estimate its prevalence at about 5 or 6% worldwide, a figure which skyrockets once patients get over the age of 60. Uh, Risk factors for it include advanced age, like I mentioned, but also skin diseases, which may affect the hands and feet, things like tinea pedis, tinea manuum, psoriasis. Uh, Diabetes or other immunosuppressive conditions can increase risk for this entity, also peripheral vascular disease, or even external physical factors, such as occlusive shoes or hyperhidrosis. Uh, Most therapies that are directed toward onychomycosis are necessarily directed towards dermatophytes, those being the genera of fungi which can infect the skin. So microsporum, trichophyton, probably the most common, and epidermophyton. So it may not shock you to learn that the same factors which increase risk for onychomycosis in the first place can contribute to recalcitrance of disease, can contribute to worse outcomes overall. As we age, our nails are felt to grow more slowly, and this may contribute somewhat to reduced clearance of fungus during the course of treatment. Long duration of disease or nails which are highly dystrophic to begin with also beget worse outcomes, as can immunosuppression, as can peripheral vascular disease or diabetes. So all these things are important to note when you're first evaluating a patient so that you can give them an idea of what their prognosis is. And we'll dig into this a little bit more when discussing kind of goals of care in onychomycosis, which you always have to be thinking about for any condition. Uh, I'll be very pleasantly surprised if anyone can identify this gentleman on site alone. But if it can happen in DC. So I'm just wondering if anyone knows who he is. Is Ford? Like, not Gerald Ford, but good. It's a justice. You got it. Yeah. Anyone know which one? It's close. It's Potter Stewart. So Potter Stewart was a Supreme Court justice from about the 1950s to the 1980s, probably most famous in the public eye for his formulation regarding obscenity, namely, I know it when I see it. So I know it when I see it may fly, in certain instances with respect to the law, but not so in medicine. I'd like for us to do a little better within dermatology and specifically within the field of onychomycosis. We can do a little bit better than, say it's giving fungus, which I will sometimes hear during presentations. All that being said, this patient's toenails are certainly giving fungus, right? But why? What are the features on exam which kind of contribute to this overwhelming impression that yes, we're dealing with onychomycosis? And I'll try to go through it point by point here. Hopefully people can see my cursor, but let's say the great toenail, right? We have a lot of nail plate thickening, kind of this ragged subungual hyperkeratosis. You can see, of course, yellow discoloration throughout all of the nails. onycholysis, which refers to the separation of the nail plate from the nail bed. You can probably best see on those third, fourth, and fifth toenails. Likewise, longitudinal ridging, which sort of implies that there's a loss of structural integrity of the nail plate. You can probably see best on the third toenail here. So all of these factors sort of come together to contribute to, hey, this might be onychomycosis, which we're looking at. What we just saw was an example of subungual distal lateral onychomycosis. So this is the kind of morphologic classification scheme we use within dermatology to kind of group different types of onychomycosis. This was published by Doctors Haneke, Barron, and Toasty, all huge names in the small world of nail dermatology. This came out in about 1998. Subungual distal lateral onychomycosis is far and away the most common, and it's the image that everybody thinks about when they think of onychomycosis. Different studies estimate its prevalence at about 60 to 90% of all onychomycosis, which is to say a lot. So in that particular entity, which gets abbreviated DLSO, SUDL, pick your acronym, the fungus invades from the distal part of the nail plate proximally, of course, favoring the lateral side of the nail plate. This is in contrast to, say, subungual proximal onychomycosis, which is a bit more seldom seen, in part because to have a fungal organism which is invading proximally, it first requires disruption of the seal of the cuticle, right? Our cuticles are there to protect us from irritants, from infection. And so it requires a pre-existing disruption through, you name it, trauma, neoplasm, infection, before the fungus can take root there. Superficial white onychomycosis over here sort of does what it says on the tin, right? It's superficial, it's white, most common organism, probably Trichophyton rubrum. And that sort of invades from the top downward. You can even kind of scrape that debris off with a curette if you so desire. Endonyx onychomycosis, it manages the trick of invading the nail plate without the nail bed. And meanwhile, total dystrophic onychomycosis is sort of the end state of most of these, right? The nail plates are crumbling, almost unrecognizable as nail plates, very poor prognosis once a patient gets to this state. Nail plates are almost totally destroyed here. So a lot of what I'm going to be talking about in regards to workup and treatment is distilled from two seminal articles, which kind of came out within the past few years. The first, therapeutic recommendations for the treatment of toenail onycho in the US. The author list here is a sort of who's who of nail dermatology and podiatry luminaries. And then this CME article that came out in the Journal of the American Academy of Dermatology from one of my mentors, Dr. Sherry Lipner, and then her mentor, the late Dr. Richard Scher. That first article in particular sort of proffers this algorithm as sort of a rough way to work up onychomycosis. So let's say you see one of those clinical signs that we went through with that first photograph, right? Thickening of the nail plate, yellow discoloration, longitudinal ridging, onycholysis, crumbling, dystrophy. If you recognize one of those things, then they recommend a confirmatory test of some kind. And there are multiple options that we'll be going through in short order. And the reason they recommend this is because there is a broad, as I've indicated with this very subtle red arrow, there is a broad differential diagnosis for those exact same nail changes. Among them, nail psoriasis, nail lichen planus, infection from organisms besides fungus, even malignancy of the nail unit. So certainly worth your time to confirm the diagnosis prior to treatment. In my mind, that's the number one reason to clip or curette or whatever your technique may be. Other reasons can include avoiding antifungal resistance, right? Within the last few years, we've recently seen dermatophyte infections sort of coming from South Asia to the United States, which are resistant to terbinafine. That's something that's occurred kind of from 21, 22 onward. Likewise, potential medication side effects, which we'll delve into in great detail, you risk sort of unnecessary exposure to those, whether it's side effects from the medication itself or medication interactions. So to drive sort of that first point home, the broad differential diagnosis, I wanted to play a game with you guys. I may not be able to see the Zoom votes, but feel free to play along as well. This game is called Is It Fungus? Is It Fungus is the game where You get to decide whether a nail pathology is fungus or whether it is something else. Uh, we'll start fairly simple. This is a patient with uh, pathology of the left great toenail. He's got subungual hyperkeratosis that is distal, that is lateral, and again, it's affecting only one nail plate. So, uh, folks, please raise your hands if you think this is fungus. All right, we have a good amount of votes for fungus. Who thinks it's not fungus? Okay, the fungi have it. So this is plain old distal lateral subungual onychomycosis. No tricks or surprises here. Sometimes things do just look like what they are. Here's a patient with a history of plaque psoriasis. All right, she has onycholysis. She has some oil spots. She has maybe some splinter hemorrhages, which are scarcely discernible at the distal end of the nail plate. So who thinks that this is fungus? Raise your hand. Nobody. Who thinks this is something else? All right, so a clear majority in favor of something else. This patient also has onychomycosis. So, on clipping, it's fungal organisms all throughout. So, this is, and I'll return to this point several times. The same changes, which sort of signal psoriasis or signal onychomycosis, you always have to exclude fungus, even if the person seems like a certain setup for nail psoriasis, right? Let's see. Here's another patient. This patient has longitudinal ridging of their toenails. They have, some sort of like hyperkeratosis of the nail plate and a little bit around the sort of in the subungual folds. They also have some discoloration of many of the nails. Who thinks that this is fungus? All right, we have a lot of votes for fungus. Who thinks it's not fungus? All right. Not fungus. You get the prize this time. So this patient has nail lichen planus of the toenails. All right, this is nail lichen planus. Probably the most characteristic change of early disease is a finding which in dermatology we call tracheonychia. So sort of this accentuated longitudinal ridging, which feels like sandpaper, sort of. If that's how rough it is if you chance to rub your finger across it. Here's another patient. They had sort of this flame-shaped lunula, right? We're looking at a very close-up view of their cuticle here. They also have longitudinal ridging. They also have sort of this vertical discoloration, which we call longitudinal melanonychia. Can I see some votes for fungus? A couple votes for fungus. Can I see some votes for not fungus? All right, there we go. So this was not fungus, right? This is another nail lichen planus case. Dr. Lipner, I mentioned her as one of my mentors before. She once said, there's two, excluding trauma, there are two real nail emergencies. One is subungual melanoma. The other is nail lichen planus, because the end stage of that disease can be irreversible scarring and loss of the nail unit. So important to suspect and identify early if you can. Here's another patient. We're looking at both thumbnails here. There's certainly thickening of the nail plate, right? There's longitudinal ridging. There's longitudinal melanonychia. There's certainly like a little bit of, I would say more thickening than subungual hyperkeratosis here. But who thinks this is fungus? All right, we have plenty of votes for fungus here. Who thinks it's not fungus? Okay, so this was endonyx onychomycosis, right? Still many of the same features as both of those lichen planus patients we just saw. But just another sort of plug for kind of confirming that fungus is there. Here's another patient. We have sort of a white discoloration of the proximal, more so than the distal nail plate. Raise your hand if you think this is fungus. All right, and raise your hand if it's not fungus. Okay, so about even this time around. So this is superficial white onychomycosis. So that subtype we went through earlier. Certainly less common than plain old distal lateral subungual, but can be seen every now and again. One clinical pearl I'll note is that, within the nail literature, superficial white onycho, which is affecting more so the proximal nail unit, is associated with HIV or some other form of immunosuppression. So, worth working that up if you happen to see this entity affecting, again, the proximal nail unit. All right, here's another patient. This patient, we're looking at their thumbnail, lots of longitudinal ridging, right? Certainly some onycholysis down here at this portion of the nail plate. We have a little subungual hyperkeratosis of some kind. We have maybe some splinter hemorrhages down over here. Raise your hand if you guys think this is fungus. All right, and raise your hand if it's not fungus. Okay, so roughly even again. The fungus had like a little bit of an edge in the election here. This is squamous cell carcinoma of the nail unit. So squamous cell, sorry, without fungus. There's a good question though. The patients can have as many diseases as they want. Let's see. So squamous cell carcinoma in the nail is almost exclusively HPV driven, to the point where folks in the field consider it to be sort of a sexually transmitted malignancy in the same way that, say, cervical SCC or penile SCC might be. Because of that link to HPV, you'll often see this sort of verrucous morphology of these subungual proliferations that we haven't heretofore seen in any of these other patients. Let's see. Here's another patient. This person has, almost complete dystrophy of the 4 fingernails that we see. Lots of yellow discoloration, onychomycosis in varying degrees for all 4 of these fingernails, reaching back from the distal to nearly the proximal nail fold. Some of these even look about ready to shed, especially the index finger here. Who thinks this is fungus? There's some votes for fungus. Who thinks it's not fungus? Okay, roughly even again. So this patient has nail psoriasis, right? So this is simply a case that's kind of progressed pretty far. Again, these 2 conditions are very tough to distinguish from each other clinically. So if you're thinking about psoriasis, just exclude, worth your time to exclude fungus first. Some subtle clues to the diagnosis here might be sort of the red, the thickening of the palmar skin. We have a couple little red to pink papules here at the proximal nail fold of that 3rd finger. But if you look at these nails and you thought total dystrophic onychomycosis, you'd be well within your rights to think that. All right, last one here. So we're looking at a patient's both thumbnails. The left thumbnail, you see thickening of the nail plate, longitudinal ridging, yellow discoloration, all those things we've seen so many times before. On the right thumbnail plate, you see onycholysis and really almost like total shedding of that lateral side of the nail from both the proximal and distal elements. Plenty of subungual hyperkeratosis here as well. So who thinks this is fungus? All right, who thinks this is not fungus? Okay, everyone's a winner on this last one. So onychomycosis of the left side, squamous cell carcinoma on the right side. So comes back to, patients can have as many diseases as they darn well please, right? So great job, everybody. I mean, and at the end of the day, the point of is it fungus is not whether it's fungus, right? And it's not even the friends we made along the way. It's that the same changes which we associate with onychomycosis can be found in a bevy of other nail pathologies, whether inflammatory, whether infectious, malignant, that can carry all sorts of different ramifications from, psoriatic arthritis with nail psoriasis, nail scarring and lichen planus, and of course, a malignancy in the case of squamous cell carcinoma. So how do we go about working this up? In short, you have to take off a chunk of nail and you have to do something with it. That's like the really short version of this, but there are multiple ways to go about doing that. In dermatology clinics, we very often will do skin scrapings to, say, work up ringworm and see if dermatophyte's present there. And the same can be done with, say, curetted fragments of fragile nail plate. And you can also send that for PAS or GMS staining to your friendly neighborhood pathologist. The same can be done for fungal culture, right? Just a bit of a longer turnaround time. We love to clip the nails in dermatology clinic, especially if you have a pair of double action clippers like these for the very thickened onychographotic nails. And you can similarly send that for PAS staining. You can send it for fungal culture. You can even send it to a fancy lab for PCR if you so desire. I tend to clip. I think it's the best way to get a big healthy specimen. I think in terms of what might be feasible for the workflow of an internal medicine clinic, I wonder whether, like, say, curettage for culture might be the easiest to sort of build in, depending on how sort of fragile the nail plate is. Of course, if you see something that raises your suspicion for a clear, dangerous alternative etiology, such as a worrisome longitudinal melanonychia, where you're thinking, okay, is this subungual melanoma? Or if it's some sort of subungual growth or tumor where you're worried about some other sort of malignancy, I would send for imaging or biopsy as the situation demands. But for most situations, clipping, curettage, these can get the job done. Um, they don't teach this in med school, and that's because you may have learned it earlier in life. Um, if you can clip your own fingernails at home, you can clip a patient's nails. The main thing to get used to is just to exert the amount of force necessary, and that's why sometimes you need those double action clippers to really get through thickened nail plates that can be pretty resistant. Um, the main thing is that, as at home, right, specimens may go flying. Not that it affects the outcome, but you don't want to kind of lose them in the clinic room either. And so a lot of practitioners will either use a gauze or a specimen bag to sort of catch flying fragments of nail. The more you sample and the further proximal you go, the greater your likelihood of catching fungal organisms. Right? There are some nail labs that I work with that just say, hey, that distal end you clip, throw it away. Just send us the proximal end. I don't throw it away. I still send it anyway, but it's just to say that your likelihood gets higher the further proximal you sample. There are a couple of morphologic edge cases that I wouldn't lose sleep over, but they can often demand some alternative methods of sampling. So say superficial white onychomycosis, that subtype we went through, you might not be able to clip that off. You can instead maybe curettage that superficial debris, like I mentioned earlier. True proximal subungual onychomycosis, that's not affecting the distal nail unit at all. You may need to either curettage very aggressively or alternatively even get like a punch or trephine specimen. But again, most of onychomycosis is that subungual distal lateral, and you'll be able to access that through clipping or curetting. Okay, I promised I would talk about goals of care here, and here we are. So let's say you've confirmed the diagnosis using one of the methods above. Fantastic. I think then the next job is sort of to contextualize for the patient what they can expect from therapy. Within the world of onychomycosis, there are a few linked definitions of cure. The first is mycologic cure. Mycologic cure means that the fungus is no longer there when you sample a second time, right? You've cleared the fungus. A clinical cure means the nails look normal again. Whatever dystrophy there was or discoloration has reversed, and you now have perfectly normal nails. Complete cure, you have to have both mycologic and clinical cure. So between mycologic cure and clinical cure, which one do you think patients care about the most? Clinical cure, far and away. Which one's do you think is the toughest to do? Clinical, hands down. So especially if the patients carry, we talked about all those risk factors which can lend a sort of a negative prognosis, whether that's peripheral vascular disease or diabetes, but especially the extent of dystrophy starting out, the length of time the disease has been present. All of those can contribute to tougher cases. So for that reason, I think it's important to sort of set expectations early, especially in patients with a lot of risk factors who have had a lot of recurrences or who have very dystrophic nails. We might clear the fungus, but the nails might not look totally normal again. Treating fungal infections can often be like fairly simple, even pretty fun. Preventing relapses is often the hard part, and especially for the patients, it can be very labor intensive, challenging, and frustrating. Um, Relapse prevention is another concept which I introduced early on in treatment, especially for those patients who have had like multiple bouts and come to me saying that they've had 3, 4 courses of terbinafine previously. There are certain measures you can take to try to prevent whether it's tinea pedis, onychomycosis, or both from happening again. Of course, treating concurrent tinea pedis is a good idea. Treating the shoes is very much a good idea. So patients can use either prescription or over-the-counter antifungal powder to go after this. Some patients, when I mention shoes, they will just say, "Hey, I'm going to throw away all my shoes right now," just in a condition of disgust. You don't have to do that. It's not necessary. You can just treat the shoes you have. If you want to treat the socks, laundering white socks with bleach is a great idea. Studies of this have found that to be fungicidal for color socks, you really have to be using hot water up to about 60 degrees Celsius or so. So I just tell patients to kind of crank the heat on the washing machine as high as it'll reasonably go if they want to go after their colored socks. Surface management can be key, that whether it's carpets or shower floors. Arthroconidia, which are the pathogenic element of dermatophytes, can often hang out on both those surfaces. So making sure that carpets are vacuumed and shower floors are bleached can be pretty crucial. sort of minimizing exposure to gyms and saunas as much as you can, and also wearing more ventilated shoes. I want to briefly look at topical treatment before we get into systemic therapy. I don't want to get bogged down too much with any individual agent. I stop here just to point out that this can often be a very labor-intensive course of therapy, and I don't shy away from that with patients. Especially like say take cyclopyrox. You're undergoing a 48-week course of therapy for mycologic cure rates which are fair at best, and complete cure rates which are pretty dismal. And especially if a patient has multi-nail disease, like this is a lot of work. Uh, and I think efinaconazole is a little bit better than the other two, but still not perfect, and it can be a little bit of a pain to get covered. And so I think for that reason, it's especially important to appropriately contextualize the risks of systemic therapy so that patients can make an informed decision about which route they're going to go. As a brief side note, combination therapy with both systemics and topicals, I think is totally reasonable, and a lot of practitioners do it, but I don't want to get too far afield from the systemics, and here they are. So these are the FDA-approved and off-label antifungals that are in most common usage by dermatologists. Terbinafine, you'll see, is certainly the best mycologic and complete cure rates, and it's the standard of choice for this condition. Therapy of choice, I'm sorry. It's a 6-week course on the fingernails, 12 weeks on the toenails. Toenails just grow more slowly. Itraconazole is second line. You can use it in pulsed fashion over the course of a couple of months for the fingernails, but for the toenails, it's still a 12-week course. I do want to point out that fluconazole often gets used as an off-label therapy dosed weekly. Some patients find it a little more attractive, whether it's a kind of decreased risk of hepatotoxicity from weekly dosing, reduced medication interactions, but you trade that for reduced efficacy. But I think that's sort of a shared decision that I'll make with patients sometimes. These are a couple of off-label regimens for terbinafine, say for cases that are difficult or which you anticipate may be difficult. Gupta and colleagues performed a meta-analysis of different off-label, either like pulsed regimens in comparison to the standard 250 daily dosing. And of these found that only the sort of 250 a day with 4 weeks on and 4 weeks off was non-inferior to standard dosing. And so to my mind, it's probably the best supported by what literature we have. Booster dosing is an interesting concept, and some nail dermatologists will use that. This sort of leverages the onychophilic properties of terbinafine. Terbinafine hangs out for a long time within the nail unit. It's peaks in concentration about 18 weeks after you start therapy, and it's detectable in the nail unit for about 30 to 36 weeks. So the idea is by giving a booster month or so of terbinafine, you're sort of extending the duration of its stay within the nail plate. And so again, these are things that I use for particularly tough or recalcitrant cases. So now we'll finally start to sort through the side effects a little bit here. These are sort of the on-label listed frequencies of all of these. Headache, metallic taste tend to be self-limited. Rash, of course, we in dermatology have a particular interest in, and that can mean a lot of things. Many rashes will be localized, or it'll be due to, say, photosensitivity and self-limited. If they are progressive and generalizing, that often means, say, plain old workaday morbilliform drug rash, because terbinafine can very seldom induce generalized rashes which are life-threatening, say acute generalized exanthomatous pustulosis or AGEP. I do counsel patients, if you have a rash and it keeps going and it is everywhere, please stop the medication, let me know, we will take it from there. Particularly so if it's accompanied by systemic symptoms of any kind. One other thing I do want to mention, I don't want to get too far afield with every single rash that terbinafine may provoke. Because terbinafine can induce or exacerbate subacute cutaneous lupus erythematosus, or SCLE, I do sort of screen for a personal history of systemic or cutaneous lupus, and I might look elsewhere if that's present. And I sort of have a conversation with the patient about it if they have, say, a family history of one of those. transaminitis is probably what we'll spend a lot of the back half of this talk on. 3% is a number that we'll keep bouncing around throughout it. This number encompasses, but by no means represents, the frequency of true liver toxicity when terbinafine is given, and we'll dig into that a little bit more shortly. I didn't have a better place to put it, but I counsel every patient for whom I'm giving systemic antifungals, please avoid alcohol while you're on this medication, just given the effects on the liver kind of throughout the azoles with terbinafine. All right, so this is, one of my favorite articles to come out in a while. I think we're very good in medicine at sort of enumerating the side effects of our medications or the risks of our procedures, but sometimes it can lack the context that's needed for a patient to make a good informed decision. This came out a couple of years ago now, and here the authors put together causes of death in the United States from actuarial data and paired it with the risk of adverse effects from systemic medications in dermatology. So on the left-hand side, causes of death, right-hand side, the risk of liver toxicity, not transaminase bump, but toxicity from terbinafine, which they found to be about 1 in every 50,000 to 120,000 prescriptions. This was, and they use it for other systemic medications, but I found it was really great because, I think a patient can really wrap their head around that, right? Once you start saying things like 1 in 10,000, 1 in 100,000, 1 in a million, what do you do with those numbers? But I think if you tell someone the risk of you getting a true liver injury from this medication is between your risk of not getting, but dying from a bee sting and dying in an earthquake, I think that lets them contextualize that risk a little bit better. This was a paper out of Sherry Libner's group at Cornell. They looked at about 950 patients who were prescribed terbinafine for onychomycosis. So of the patients they sort of analyzed, about 3% of them had LFT abnormalities at baseline. During the course of treatment, the overwhelming majority of them resolved without any sort of intervention. The other 3 who started out with LFT abnormalities just completed treatment with no problems. 2.5% of them developed abnormal LFTs during treatment, again, kind of hovering around that 3% number. Of those, 17 of them resolved after therapy was done. For 4 of them, therapy was stopped and they resolved after that. 2 were lost to follow-up, so we don't have that info. One thing, big takeaway from that paper for me was that the patients with an LFT bump were about 3 times more likely to be over the age of 65 years old. And so that kind of said to me, like, okay, it's probably worth monitoring those patients a little bit more closely. This was a similar study, but more highly powered, that came out in 2018 in JAMA Dermatology, which looked at terbinafine administration in patients who were coming in not just for onychomycosis, but for all dermatophyte infections. And they found pretty similar numbers. 3% of the patients are kind of had LFT abnormalities over the course of treatment. But again, these were largely, if not all, self-resolving. They were all grade 1 abnormalities. And so, even though neither of these studies, right, are really powered to capture an outcome of liver toxicity that occurs 1 to every 50 to 100,000 prescriptions, I think they do sort of support each other in saying that the transaminitis which occurs with terbinafine administration for this disease is pretty rare, it's pretty mild, and tends to self-resolve. Now, what about when liver toxicity does happen? So these authors looked and they published in the British Journal of Dermatology. They looked at 69 cases of true hepatic injury, liver toxicity due to terbinafine. In every single case they examined, the labs did not catch it. The symptoms always preceded the abnormal lab findings, even if the patients were undergoing monitoring. And so they sort of put forward that there was no utility in lab monitoring for, in the case of terbinafine for this condition. I don't know that I'm all the way there yet, but it has certainly sort of stuck in my mind this idea that, and I kind of tell it to patients too, like we may, even if we're monitoring labs, we may not catch it. And so I take great pains when I'm talking about terbinafine to go through with them. Here are things that you look for which you stop the medication, you call our office, scleral icterus, lingual jaundice, pale stool, nausea, vomiting. I don't have to tell you guys. But that's sort of the effect that it had on me. Finally, there was one here. This is kind of a follow-up of Sherry Lipper's group, and they looked at, whereas they had excluded these patients in that prior study with 950 onychomycosis patients, here they included or rather they just analyzed on their own, the folks with pre-existing hematologic or liver abnormalities. So of the 81 patients that had baseline LFT abnormalities, it was a little bit different of a picture, right, than the folks who kind of came in without liver disease. None of those transaminases got better during the course of therapy, nor did they get appreciably worse. And most of these patients had grade 1 elevations going in and stayed there. So although it's not every day that I will be treating with someone with ongoing liver disease with oral antifungals, I think in the case of someone whom you can monitor frequently, who has stable disease, this does give you a bit of a leg to stand on. And in terms of synthesizing all this, right, you have a risk of transaminitis that is low but present. You have a list of liver toxicity that is lower still but present. The way I synthesize all of it is by monitoring my patients who are 60, 65 and older, or who have several comorbidities a little bit more closely. Certainly I'll get baseline LFTs, but I also, again, make sure to have a chat with them about, what are the signs and symptoms of liver failure so that you know when to stop this and go to the emergency room. All right. Any treatment with oral antifungal, whether it's terbinafine or whether it's one of the azoles, does require a thoroughgoing med rec. Terbinafine interacts most strongly with the CYP2D6 system. This list is by no means exhaustive, but kind of represents the agents that I'll see most commonly, which might interact with the medication. So the 2D6 substrates, if you give terbinafine alongside them, they may increase the concentration of the substrates. Likewise, if you give one of the inhibitors along with terbinafine, you'll see increased concentration of terbinafine. And as you can see, there are many classes which sort of occupy both lists. I do want to give a flyby of the other options before we sort of close out today. So itraconazole is second line for onychomycosis. It's not nearly as commonly used. I do screen patients for any personal family history of cardiac disease because of the black box warning for ventricular dysfunction. Likewise, I look for any medications which are 3A4 dependent or which may cause QT prolongation. The common side effects are pretty similar to terbinafine overall. I was always taught in residency to get a CBC with this because of the very rare outcome of neutropenia. That risk, so far as I found, is so small, it's tough to quantify, but it's just how I was raised. Abnormal LFTs, you'll see at a similar frequency to terbinafine. And again, serious hepatic adverse effects are pretty uncommon. Fluconazole, we kind of talked about the pulse weekly dosing that gives a little more flexibility for, say, patients with many medications to begin with. I will, still look for 3A4 medications, 2C9, anything that will prolong the QT interval. I monitor LFTs with this at baseline and periodically, but there are many reasonable dermatologists who don't even do that because of the weekly pulse dosing. But I mean, one thing I am sure to impute is that I'm very clear that this is off-label therapy, number one, and such meta-analyses as we have comparing the outcomes of terbinafine and fluconazole in onychomycosis, it's decidedly worse cure rates. These are the fourth line options. Full disclosure, I've never tried either of them, but I'm throwing them in for completion's sake here, just because this is kind of like the frontier of what people are doing, at least in dermatology. Posaconazole and voriconazole, folks that I've seen publish on it have recommended, say, EKG monitoring because of the risk of QT prolongation, and visual screening because of the abnormalities that may be caused by voriconazole if you're going to treat for more than 28 days. And in most cases of onychomycosis, I suspect you're going to treat for longer than 28 days. To be honest, if I had a patient who was recalcitrant and severe enough and was willing to try one of these things, I would probably take my hat in hand and seek advice from one of my ID colleagues. But this is just so you know kind of what's at the frontier, what's being done right now. So we got there, right? I think that what I want you all to take away from this is not all that glitters is mold. You know, there's a broad differential diagnosis that accompanies those findings. We immediately take as just onychomycosis. And for that reason, it is worth confirming your diagnosis in some way. Terbinafine is the gold standard for this condition, and certainly has cure rates that well surpass the topical agents that we have, and certainly the other oral antifungals. Uh, it is worth going over the hepatic risks and of terbinafine, but certainly worth contextualizing them because of how seldom they occur. Um, and just contextualizing the low frequency with which they can happen. Um, Here are my references. You guys have been great today. Very game for Is It Fungus? And yeah, I'll take questions at this time.